Hello everyone, and before we begin tonight's webinar on the title of the important role of primary care in follow-up for cancer survivors, I wish to acknowledge the First Nation traditional owners of the lands to which we meet today for this webinar. And I pay my respects to the elders, past, present and emerging. My name's Justin Say, I'm a GP in Victoria and also Clinical Dean at St Vincent's Clinical School. And it's my pleasure to host tonight's evening. Before we introduce the panel members, I'd like to introduce the Australian Cancer Survivorship Centre. I would like to take the opportunity to acknowledge the ACSC in the development of this webinar. The Australian Cancer Survivorship Centre is a multidisciplinary team working to improve outcomes for cancer survivors. Since 2010, the ACSC has been working with health professionals, survivors, community organisations and policymakers to provide information and support to survivors and carers, educate and train the health professionals, and cancer survivorship leadership and guidance. I would also like to take the opportunity to acknowledge the Victorian Department of Health and Human Services for funding this webinar. There are other partners involved in this collaboration, and this includes the Cancer Council Victoria, APNA, and the VCCC. This webinar is intended audiences for GPs and also primary care nurses. We've based the content on a number of key areas. What is cancer survivorship care? And explore models of care, including shared care. We'll also look at supportive care, including side effects of treatments, late effects management and unmet needs. And we'll move then to what are the enablers of care by using a team-based approach and the role of MBS items support our patients. And finally, what tools, education links and supports we can offer to our patients, and in particular from the Cancer Council of Victoria and the ACSC. I'll now pass on to the panel members that will participate in this evening's meeting. I'll start off with Joel. Do you want to introduce yourself and say a few words about yourself?
Yeah, thanks very much, Justin. So my name is Joel Ree. I'm an Associate Professor of General Practice at University of Wollongong. I'm also a GP, obviously, and I practice at the Hammond Care Centre for Positive Ageing and Care, so mainly with older patients and people with end-of-life care needs. And also, I'm the current chair of the RACGP network, the Cancer and Palliative Care Specific Interest Network. Thank
you, Joel. I'll now move to Magali and Ross. Magali, do you want to introduce yourself and say a few words?
Sure. Hello, everybody. My name is Miguel De Castro. I'm a primary care nurse. I do a lot of nurse education, GP education, particularly around the area of chronic disease and chronic disease management and things like that, and very passionate about anything to do with the role of primary care nurses. That's me.
Thanks, Magali. Ros.
Yes, I'm Ros O'Reilly, so I'm a primary healthcare nurse at East Brunswick Medical Centre. I've been here for the past 15 years. Also a member of the GP Liaison Board at St Vincent's for the past 12 years now, and a part of the PC4 GP Circle cancer research trials. So very, very passionate about cancer survivorship and where we can assist our patients and move forward with better outcomes within general practice. Thanks, you.
Rod. Catherine, throwing it to you.
Hi everyone, my name is Catherine Lane. I'm the Head of Cancer Information and Support Services at Cancer Council Victoria. I'm an oncology nurse by background, and I'll be chatting a bit later tonight about, I guess, the role of Cancer Council and the support services we can offer and how we can support primary care practitioners and nurses in allied health to support cancer patients in the survivorship phase.
Thanks, Catherine. And finally, Meg Rinderman, and Meg will introduce herself, and there's also a case that she'll present on our behalf for this evening. Thanks, Meg.
Hi everybody, my name is Meg Rinderman. I am a cancer survivor. I have a 27-year history of four cancer encounters, Hodgkin lymphoma 3 times, and breast cancer requiring a double mastectomy and reconstruction. So every type of treatment we're likely to talk about, pretty much, I've encountered. Over the years, I have become involved as a consumer representative and an advocate in the survivorship space. And I am passionate about putting a face to survivorship. So my face for the Survivorship Centre at Peter Mac is the face of survivorship, I guess. And I tell my story often to educate healthcare professionals and help them understand more about the consumer side of survivorship. So to kick off tonight, let me introduce Ben to you. Ben is our survivor. He's a 63-year-old male. He's spent his working life as a mechanic. He's married to Jane, who's 61, and she works part-time. Jane and Ben have no children, and they live in rental accommodation. Ben is overweight, he's a smoker, and a regular drinker. He has a GP, although he rarely attends. Ben's paternal grandfather has a history of bowel cancer, but Ben has not participated in the national screening program. Ben found blood in a bowel motion. He was diagnosed with stage 2 colorectal cancer. His treatment included adjuvant CCRT, FOLFOX, ileostomy, resection, and reversal of the ileostomy. Amongst the issues that Ben encounters is a morbid fear of his cancer coming back. He suffers peripheral neuropathy and issues with thinking and memory, often referred to as chemo fog. He's constantly tired. Pelvic radiotherapy has led to osteoporosis and increased risk of pelvic fracture. Surgery and his radiotherapy has impacted on his maintaining an erection. He worries about the changes in his sexual relationship, his inability to maintain an erection following his treatment. He's unable to return to work due to his symptoms, and this has financially impacted on he and Jane. So bear Ben in mind during our discussions tonight. Back to you, Justin.
Thanks, Meg. And in case that we'll refer to throughout this evening. Without further ado, Joe, I'm going to throw out the first question. And when we talk about cancer survivors and their care, who and what are we talking about?
Yeah, cancer survivor, I think, is it's not a commonly used term in general practice or primary care. So I think the closest analogy, well, not analogy, but closest term that we use in general practice are people who've got a past history of cancer. I think basically the cancer survivor is referring to people who have already undergone treatment and usually people who have undergone curative type treatment. So that's who we're talking about generally. But of course, people who have nowadays, especially with more advanced therapy, it's sometimes not easy to tell the difference between someone who's sort of, had curative intent treatment versus someone who's on a palliative phase. A lot of patients are basically receiving, say, immunotherapy, sort of patients who would have normally, say, even 5 years ago, would have been offered palliative therapy would now be on immunotherapy. So I think that distinction has blurred a lot recently, but traditionally we're talking about people who have survived cancer treatment and therefore we call them cancer survivors. There are different definitions obviously used by different groups, and COSA, which is the Clinical Oncology Society of Australia, which is a big organization for cancer, they sort of consider cancer survivor as people who have been diagnosed with cancer from the time of diagnosis onwards for the remainder of their lives. So it is basically a term that's, once you get it, I think it stays with you for the rest of your life. I think in terms of cancer survivor, it's becoming more like a chronic disease management. I think that's the key thing. So whereas before we used to think, or a lot of patients used to think, okay, you mentioned the C word, if I catch cancer or if I get cancer, how many years do I have? That used to be the question. But nowadays, it is becoming a chronic disease management, particularly with newer therapies. And so I think not only specialists, but primary care also has a critical role in coordinating care, managing multimorbidity in these patients, and secondary prevention, because many of these patients, the cancer survivors, will live a long time. Whether that's 5, 10, 15, 20 years, they will live a long time. So life goes on, and they do require highly effective care, not only for their cancer, but for other illnesses. And I think there's a real opportunity for primary care to provide better access to care for these patients. And I think the other thing I just wanted to mention before I finish was basically, in terms of research, trials have shown that GPs, when they're leading follow-up and when they actually set up models of shared care, they've been shown to be as effective as specialist-led oncology care when managing particular patient groups in terms of survivorship care. So that's something to think about.
Thanks, Joel. And we'll talk about shared care a little bit later on. But you did touch on a point that many of our patients are living, fantastic lives after being diagnosed with cancer. And I might throw you to Ros, the role of primary care nurses. And you have a great relationship with your patients prior to a cancer diagnosis. And what do you consider the role of the primary care nurse during and after treatment?
Yeah, I think from my perspective in general practice and the way we've run with it, being a sort of a new concept for us is cancer survivorship, because we understand that during diagnosis and treatment that the patient to us can be lost to their specialist care, and we believe that care obviously is happening, but it's, to me, predominantly, it's when the patient returns. They'll return either more than likely or possibly with a cancer survivorship care plan. That would be my role then to step in and say, well, let's put a plan in place going forward to make sure that all the supports have been put in place for you, so that the patient is getting overall holistic care. And we may not be just talking about physical or setting up recalls that you're having this blood test or that mammogram or what have you. We're also talking about financial. What is their situation going forward financially? If they've been out of work for some time, or their position at work has changed, or their eligibility to work has changed. So we're talking about other areas. So financial, emotional. How have they been supported? Where are they at now going forward with their fear of recurrence? So it's quite a large scope of areas to look after, but it is so rewarding, very rewarding. I feel that's where my role steps in at that stage. Yeah.
I think the emphasis on there is a team that can manage a patient, and I guess, MacCallum, can you give us an example of how this would work? And obviously we've got the case for today, but you might want to share a personal example in your management of patients with cancer.
Yeah, I think Rose covered it beautifully as well when she was talking about looking at that whole person. We do get that privilege of being able to engage with them most of the time before that cancer diagnosis, sometimes throughout the treatment phase and even after. So being able to have that really strong therapeutic relationship, you can be that constant person that they can they know they can contact, they know they can reach out to, they know they can ask questions, and it's that trust. That's probably the absolute best point. And as Roz said, just being able to look at the whole person. So understanding that just because you hear the C word, and this happens for us even as clinicians, that you go, we'll leave that to the oncologist, and particularly in general practice, it doesn't have to be the case. And one of the things that we find with particularly a lot of practice nurses is they feel like, oh, this is not my area of expertise, so I just won't even, I'll almost avoid that patient. And instead of that, I think it's actually important to lean in and go, look, you're not expected to know everything about everything. Something that you're not an expert on, that's fine. Be upfront about it and go, actually, I don't know about that particular thing, but let's find out together. Let's connect you with all these different providers. You become that care coordinator in a way, or that connector, that trusted connector. I think that's probably the biggest thing. And that's been my experience, like having people coming through with an ovarian cancer. I have no idea how to create a care plan for this person. But then again, that the cancer treatment wasn't my area of expertise, and that wasn't the only thing happening with them. And when you're talking about quality of life, what are they finding is the biggest impact? What a lot of it is, it's well in the realm of what we do in general practice. So yeah.
I know, and just your comments just reminded me that our patients, they get to know the nurses sometimes even better than the GPs, and this is before the diagnosis. So it might be a wound management, and then a year later it might be the management for breast cancer or another cancer, and you do have that trust and that rapport that is built over years. So I think that is an important element that's been highlighted. Joel, so the number of cancer survivors is increasing, and cancer survivors are living longer, and we're hearing more about the role of the GP in shared care following cancer treatment. Tell me, what are your thoughts of shared care and the role of primary care nurses and GPs?
Yeah, so shared care, I think, is going to be a big thing, I think, in the next 5, 10, 15 years, even the next couple of years, I think. It's basically a model of care where the care for the patient is shared between primary care and the specialist provider. So in the context of, I guess, cancer, we're talking about oncology services. So your radiation oncology, or whether you're medical oncology or your surgical specialist, etc. It seems to be suitable for a lot of patients with cancer, but obviously not everyone, because some patients have very rare cancer, or they have very complex sort of situation. They might have very difficult personal circumstances, or maybe there's some problems or issues in terms of their capacity for self-management. So has to be tailor-made for each person. And obviously, as the person's situation changes or their clinical circumstances changes, then you sometimes you do have to, maybe the person was getting shared care initially, but they might have to move to a different care model later. But I think there's great benefit. So in terms of the subtypes that shared care model has been talked about and trialed in, breast cancer is one example where such a model has been recommended by Cancer Australia, for instance. But even, prostate cancer, you're probably aware of a fairly a big trial that was happening. And also blood cancers. I know that there's some studies which is about to start in blood cancers and other types of cancers as well. So it is a very interesting area. And as I mentioned earlier, several trials have shown that cancer survivors can be safely and effectively managed by GPs and in conjunction with specialists. And there are some components of this shared care model which seems to be important. So you can imagine that obviously the number one thing is effective teamwork. And that's obviously a very important part. And that also means there's a good communication between the specialist and the GP. And basically it includes the GP receiving a copy or some information about the patient's treatment, their diagnosis, their what kind of side effects, whether it's short-term, medium-term, long-term, can be expected from the patient's treatment and their disease. Also, very clear and concise guidance, because obviously one of the issues that GPs have is that even a very busy GP don't get to see a lot of patients with a particular subtype of cancer. And that's obviously worse if you've got a rarer cancer subtype. But so it's very difficult for us to become extremely familiar with all the protocols of follow-up care for individual cancer. So it's very important, I think, for cancer services to share that information with the GPs. Also, obviously recognizing that, primary care nurses and doctors have expertise, and so that they can work together well. common problems, and I think nurses and GPs in the primary care are very good at managing a lot of common problems, and we'll talk about those later. But also the other important thing is accessibility to specialist advice, because I think many of us in primary care might get a bit worried. What if we handed this patient and then something bad happens or something concerning happens and no one's picking up the phone? Maybe it's after hours and I can't get in contact with anyone. What happens to the patient? So, and that is a very valid concern. So I think just ensuring that the patient can be integrated, or they can re-access specialist care, and having that pathway available, I think that'll be really important as well. I think the other thing is, Meg's sort of nodding, and obviously the important thing is the patient has to be on board as well, because the patient might have a preference for specialist-based care. Many patients would strongly prefer shared care model. So obviously ensuring that the patient gets a choice and making an informed decision as well. I think all of these are important.
Thanks, Joel. Meg, do you want to comment on shared care? Obviously your thoughts on whether shared care can be done effectively in primary care.
Yes, I'm a living example of it. I'm a participant in shared care. There's a couple of things that I think I would like to comment about, and one is it's a comment that I often make when I'm talking to healthcare professionals, and that is that as a patient, when we're diagnosed, it's almost as if we have a giant capital C emblazoned onto our forehead. And particularly when we're going through our treatment, our diagnosis phase and treatment phase, the people we come into contact with in the hospitals see us as the cancer patient. When we return to our GPs, that's our trusted home. The GP knows us, the primary care nurses know us. They know our families, they know our children, they've given us our vaccinations, and they've treated our flu and all of our other things. So it's like coming home. So where it's appropriate and where patients are happy to be involved, absolutely shared care is a perfect model. For me, every other year I go into the hospital for my tests and my screenings and what have you, and then the following year I have that with my GP. But in between, I can go to my GP for niggles that might be worrying me, anything that I'm concerned about. I think that probably covers it.
No, thanks, Meg. And just with shared care and John Embry's work on prostate cancer, and Joe did mention some concerns about illness trajectory change and be able to link back in. And that's where the models that have worked well is being able to negotiate and quick access back to a hospital and hospital team. So I think that's something that we need to work on. Obviously, there's good work and we need to continue the good work. To the topic of management of a comorbid illness, an important area. So Magali, over to you. How can we integrate cancer survivorship with management of comorbid illness? How can we do this better with the emphasis on integration?
I think a big part of it is, as Meg was saying, like being mindful of that C on the forehead. Like it's like, look at the person. This is a whole human being. Look at them holistically. Don't treat them differently because of that cancer diagnosis. And obviously, yeah, in terms of we need to look at their cancer related issues and potential complications in the treatment. But aside from that, there's still going to be everything else that we do for any other patient in terms of lifestyle risk factors, any issues in terms of their quality of life. Mental health is going to be a huge one, particularly during this time or even after. So not forgetting about those things. Again, practice nurses in particular, we tend to, if we haven't been trained in mental health, we tend to go, oh, just stay away from that. But there's no issue in bringing that up and passing it along to the GP to do a full assessment. Make sure that you're constantly reminding the patient essentially that this support is available, that if they ever have any questions or any concerns, we can plug them in. There's services available for them. In terms of that integration, as I said, a lot of the work that we do in chronic disease already with any patient is around coordinating the team care arrangement, for example, where we're looking at allied health. We're looking at, what are the services that make sense? What specialists are already providing services for this patient? So in a way, it's not really that dissimilar, or if at all different to what we already do. So it's almost like it's what I found in my journey as a nurse and training other nurses is just to get out of your own way as a nurse, because it's your own, or as a provider, it's your own kind of ideas of, I need to, that's your own judgment. Like, you don't need to treat them any differently, treat them as a human being, essentially. And you already have all the skills in terms of that multidisciplinary coordination and all that access of services. It might become an opportunity to learn more about the cancer specific services. And that's where I think like Catherine's gonna cover some of the resources that are available. Because again, you're not expected to know everything.
So Magali, you remind me of a famous Canadian physician, William Osler. And a famous quote is that clinicians should not treat the disease, but a clinician should treat the patient with the disease.
Yeah.
And I think you've emphasised that point nicely with Meg. Just with, I guess, our case study, Magali, Ros, are there things that you would incorporate in terms of some of the MBS items available to clinicians, to primary care nurses?
Sure. Well, there's definitely, I'll start and then I'll pass it along to Ross, and she can plug in anything that I miss. There's a lot that can be done. And one of the first things that I'd be identifying is get an idea of where's Ben's mind at right now? What are his priorities? And what is he perceiving as the biggest issue at the moment affecting his health? Because you might be surprised to find out that it's actually not the cancer diagnosis. It might be that erectile dysfunction that's the biggest issue, or it might be the work that is the biggest issue. And even though they're not technically health related, they are having an impact on his health. So there's no point in me like focusing on a different area, thinking that, I know best and this is what needs addressing. I'm going to get zero buy-in from them. Also being mindful of their health literacy, what's happening there, how much do they understand in terms of what the treatments and what their diagnosis is, or the prognosis, whatever it is. So again, and as we have that conversation, this would be done obviously along with the GP, would be looking at, well, what are the services that make sense? What are the services that he's already plugged into that we may not know about? Because a lot of times patients have allied health services and other providers that they see and we have no idea that they're seeing. So they should be brought in as part of the plan. But yeah, I'll pass it along to Ross because I'm sure she'll have more details there.
Yeah, no, I agree with Magali. I think I start back at the beginning, like I talk to the patient about their journey, what's happened to them, what they've suffered, where they're at now, and what they have accessed and what's happening for them, and where they would like, what's important for them for going forward. What do they think are the issues that are really troubling them now that they want that assistance with? And certainly with GP management plans, and the cancer is a chronic disease. I put it in the same boat. CDM, chronic disease management, cancer, it comes under the same banner for me. And I would work towards, with team care arrangements, setting that up as into what they want. We'll look at the case study. I mean, Ben's overweight, he's a smoker, regular drinker, he may have lost weight treatment, but certainly if he's still smoking, well then we could organise a quit educator, but within the banner of the TCAs it could be even exercise physiology to work out a strategic individual management program for him for exercise. I would keep myself, I would look at the psychologist under a mental health care plan. I know that the psychologist can be used in the team care arrangements, but it is only your 5, visits a calendar year that you do get the subsidised rebate. I mean, they can still go on regardless. But I would tend to use a psychologist under the mental health care plan and divvy up what would be specifically needed by that patient as regards allied health. upon that, I go beyond that and I just work through with them. What resources have you accessed, or what has been discussed with you that is available to you? Do you know that you can, ring the Cancer Council? Do you know that you can receive free financial advice from the Cancer Council? So there's so many areas, but we build it together, tailor it individually according to that person, and me understanding myself, if it was me, what would I think that would be needed to support me going forward and to support my relationships with my family. Yeah. So as MacCallum said, it's not, we don't need to have all the clinical skills. It's about supporting a person holistically, and each one is different as to where they've come from, how they're suffering, how they've dealt with it, and where they see themselves moving forward. We don't streamline it that they're all going to fit into boxes and move forward. Everybody is completely different, and everyone will have an individually tailored plan. And I think it's best under a chronic disease management plan, because I think then what you're going to do is follow through with your reviews. And I think it's ultimately important. I always say, don't create a GP management plan, chronic disease management plan, unless you're going to follow through with the reviews. And the reviews will be following through with your recalls. Was this scan done? Was that followed up? How did you go with that, physiotherapist? Didn't like them? That's fine. There's plenty others, so we really got to, and keep that momentum of the contact. And I think that's what, MacCallum, you were talking about, is your relationship that you build and establish with the patient. Keep that moving forward so that they feel confident that there's something happening. There's a trajectory. We're moving forward.
Thanks, Ros. And it's fantastic we have the team care arrangements. We've got the mental health care plans, but there are maximum sessions available. I guess throwing to you, Catherine, what happens when patients do run out of access to, the 10 sessions with the mental health care plan, the 5 sessions with the EPC? Is there anything available through, I guess, your links and resources?
Absolutely, and it's been great to hear MacCallum and Ros and Meg referring to other resources that can support, because that's exactly what Cancer Council is designed to do. It's designed to complement both the clinical and primary care that's available to people, and especially when we think about primary care, as has been mentioned, no one can possibly be an expert in every single issue that someone would present to a primary care practice with. So it is important to know what other resources are available to you as a practitioner, to you as a primary care nurse, and to also for your patients, so that we can really fill in all those gaps at any point where something might be needed. I think it's really important to know as well that from a Cancer Council perspective and from our information and support line, one of the biggest referrals we will make, or one of the biggest discussions we'll have with people affected by cancer, is making sure, have you spoken to your GP? Are you linked in with the GP? Are they your regular GP? And what kind of conversations are you having with them? And if you're in or have finished active treatment, do you know if your specialist has been in contact with your GP? For those that are listening to the webinar, that's absolutely something that we encourage, and we will refer back to and point back to GPs all the time as part of a really important part of that person's care pathway after they've left the acute setting. In terms of the resources that are available, and I know we'll touch on them in a bit more detail later, really Cancer Council focuses on supportive care. So a lot of the elements that have been touched on already tonight. So it's really understanding where the person's at and what their issues are. And it has been mentioned already that for a lot of people, the primary concern or the primary stress they might be experiencing may not be related to their treatment or their side effects. It may be related to supportive care needs. So things like finances, things like sexual functioning and ongoing side effects, return to work, managing family relationships that have been impacted by a diagnosis. And as has already been mentioned, that fear of cancer recurrence. It's mentioned as one of Ben's biggest concerns, our case study, is that fear of cancer recurrence. So in terms of resources that are available, I think the two biggest things I can give the audience, outside of obviously connecting into your primary care nurses and your GPs, is knowing that Cancer Council is available and knowing how to contact us. That's on 13 11 20. We'll see if we can ingrain that in people's memories tonight. And also accessing the Australian Cancer Survivorship Centre's resources on their website. I know for GPs and practice nurses, knowing where to access everything and having it at your disposal can be a challenge, because there are so many things that you need to be aware of across so many different disease groups. But in terms of cancer and cancer survivorship, Cancer Council and the Australian Cancer Survivorship Centre would be two of your biggest resources that you should have in your internet browser or on your post-it notes at your desk. And to have those resources available in hard copy to give to your patients at the time, or to be able to download and print as you need them, is one of the biggest things that I can encourage. And I know we'll go into more about those resources a little bit later.
Thanks, Catherine. What we might do, we're going to have a poll and also a slide talking about some of the common side effects of treatment of cancer. I know a number of questions and comments have been made in the Q&A, and what we'll do, we'll try and get to them at the end of the session and address your comments and questions. Just a slide, I'll get people just to look through this over the next minute. It's related to chemotherapy, radiotherapy, and targeted and immunotherapies. Look, we've also got other treatment modalities. We have not included the side effects in this slide. There are common side effects common to all three treatment modalities. Some have 2 treatment modalities that have similar side effects. What's interesting with the newer and targeted immunotherapies is the single treatment side effects. So we can see with immunotherapies and target therapy, there are concerns over renal damage, fluid retention, hormone changes, and particularly with COVID-19, flu-like symptoms. And obviously with skilled GPs and nurses, a key history examination is important. What we might do is throw to our first poll. And the poll is common issues after treatment. Which of the following are common issues after treatment? And select all that apply in your field of work for our participants. And we'll give people half a minute to put their answers in. So looking at the poll, we have a number of responses from the participants. So anxiety and depression, 94% answered saying it is a known common issues of treatment. Cancer-related fatigue, it's been mentioned already, again 92%. And finally with 74 and 69%, issues with money and thinking and pain. Ros, what issues do you commonly see in your work in this area?
So I would say cancer-related fatigue, definitely. And there's, once again, there's various ways we can work through that with our team care arrangements with, whether it was exercise physiologists, experienced ones with cancer survivorship. Also other resources though, like XMed, is available to patients. Anxiety and depression, I think then once again, the whole thing of the fear of recurrence of cancer, what I've been through, the fear of recurrence, and how it's impacted, etc. So I find that patients, well, the ones that predominantly I've come across, do need support in strategizing those feelings, to be able to cope and not let them overwhelm them from day to day. So I think they would be the 2 main things. Pain, yes, but predominantly I find that as a GP specialist management, for pain medication and that, I attend not to get too wholly myself involved with that, but certainly if it is discussed with me, I'll make sure and coordinate with the GP that something is in place to be managing that, definitely.
Thanks, Ros. And I guess going over to Joel, we've talked about side effects of treatment, and these treatments in turn have late effects and complications of treatment. So how would you approach screening and preventive activities for the patient with the common cancers we deal with in primary care?
Yeah, I think one way to approach it would be obviously taking a holistic view of the patient, because many patients have other illnesses apart from cancer, and often they have other chronic diseases like high blood pressure or high cholesterol or heart disease, or basically anything that you can think of, patients can have. So I think one way to think about it is optimizing the management of all of those conditions. And that'll be dependent on their health status, that'll be dependent on their family history, their personal history, risk factors, etc. So continuing to do screening for all the conditions which is appropriate and gender appropriate. So it might involve things like mammography, it might involve things like cervical cancer screening, osteoporosis screening if appropriate, bowel cancer screening, etc. Continuing all of that. But then a lot of cancer and cancer treatment also has effect on long-term complications and risks. So, for instance, we know that certain treatments, such as radiation treatment for lung cancer, for instance, might actually cause or increase the risk of heart disease. So, and many chemotherapy treatments might, cause peripheral neuropathy, or osteoporosis might be exacerbated by certain treatments or certain conditions, especially things that cause early menopause. So I think it's really important for primary care nurses and doctors to be aware of the modifying influence that specific cancer and their treatment has, and then modify their approach accordingly. But I don't think it means that we need to go back to medical school and relearn everything, because I think we've got all the tools and knowledge that we need. It's just a matter of adjusting our approach slightly. So, for instance, if we think that the person is going to be at higher risk of cardiovascular disease, it means that we might need to be a bit more aggressive in monitoring for cardiovascular risks and starting treatment early, making sure that the patient's diet and exercise and everything's well under control. So just being more aggressive with those targets. And I think the best, probably the easiest way that GPs and nurses can get that information is obviously from the cancer services themselves, especially if there's some way to do shared care. Then that sort of information in terms of, okay, here are the long-term complications or sequelae to look out for, and the person's cancer and their treatment may have these effects. So it might increase your long-term risk of cardiovascular disease. It might not have any effect on osteoporosis. So they can actually give you a whole list, and then that'll modify your approach to those problems. But obviously, I think a lot of what we do is going to be very similar to our other patients who doesn't have cancer.
Thanks, Joel. I note the time, and I think we might actually move to common and significant unmet needs. So in addition to commonly experienced and predicted side effects of treatment, cancer survivors also experience unmet needs that impact their quality of life. And unmet needs is a concern or issue someone requires assistance with that is not addressed or provided by their healthcare. So on that note, what we might do is go to our next poll, and we'll give people half a minute to respond to the next poll question. What do you think is the most common unmet need for cancer survivors? Okay, so let's have a look at the poll results. So what do you think is the most common unmet need for cancer survivors? And the highest ranked was fear of cancer recurrence, with 49% answering to that issue. Others have to come through information about support services. So, we're delighted to have Catherine with us today. Financial toxicity is obviously another one that's been mentioned by the participants. It sounds silly, but affordable car parking at the hospitals. For me, a number of hospitals will use car parking as a source of revenue. I'm based at St Vincent's. I'll say no more about what they do with their car parking. Although there is a push for concessional car parking for cancer patients now at St Vincent's. And then the last one is needing to talk to others with a similar cancer experience, and that's been rated as the lowest. I guess, Joel, do you want to maybe go, and we'll go to a next slide and talk about the other unmet needs that have been not mentioned in our poll?
Yeah, so I think things like help to reduce stress. So I think a lot of these are obviously psychosocial. So things like changes in sexual relationship as well and sexual feeling. So that could obviously have physical dimension to it. But also a lot of it is actually due to psychological issues as well. So a lot of psychosocial stuff coming out, access to complementary alternative therapy, and needing to talk to other people who have experienced cancer, etc., not being able to do usual things. So a lot of mostly psychosocial, and that's really interesting because often we think about the physical side of things being the sort of greatest unmet need for cancer patients, but there are actually other things, even as Justin just mentioned, car parking. I mean, that's something so seemingly insignificant is a big factor, and it goes to show that obviously with cancer being such a significant diagnosis and life-changing event, that even things that the person were able to cope with when they were well, can have it can actually have really detrimental effect on the patient who's under tremendous amount of stress and pressure, and the family as well.
And mentioning of family, I can see one of our participants has mentioned the issue of partner or spouse distress. Meg, from a consumer's perspective, what are the things that, through your experience in terms of with their supports, financial toxicity, some of the things on your reflection as an unmet need from your end?
I think that all of these, the ones that are listed, certainly. I think that financial toxicity is a huge unmet need. I think for me and for every other cancer patient, cancer is expensive. Treatments are expensive. Particularly if your treatment is not all in the public system. Often when your GP sends you off for testing or whatever, it's done in the private system rather than the public system. That becomes expensive. It sounds funny to say that hospital parking is one of the greatest unmet needs, but when you're going to the hospital every day for treatment, or every week for months for treatment and tests and what have you, that's expensive if you're not able to work. There are so many elements. One of the unmet needs, what has been an unmet need, which is now more commonly addressed, is that of receiving a care plan from the hospital, so that all of that information that we talked about before in terms of side effects and late effects are actually carried with you from the hospital back to your GP, so that both you and the GP are well aware of the sorts of things that you might encounter, and that can then be dealt with in the primary healthcare setting. Stress, worry, all of those things, they impact on all of us. And these and so many others. And I suppose the last one on the list is one that resonates with me, because I actually volunteer with the Cancer Council's Cancer Connect program, which is a peer support program. And Cancer Council puts people diagnosed with a cancer diagnosis in touch with somebody else who's experienced the same diagnosis that they have. And talking to somebody who has gone through the diagnosis, the type of treatment, whatever it might be, gives people a feeling of confidence and hope going forward. So for me, that's a really important one as well. That's probably all I would say at this point.
Thanks, Meg. I guess, throwing to Ros, Magali and Catherine, we did have the case of Ben, and 3-year-old gentleman. Are there any comments from the three of you regarding unmet needs, particularly with the case in mind?
Well, I had a few points, Justin, and whether relating specifically to the case or not, but it was just that Meg mentioned about, patients coming away with a care plan from the specialist, the hospital. And it was interesting because some time back, I did a clinical placement program for cancer survivorship, which was one of the most, I think, valuable learning experiences I've had over the last couple of years. And it was interesting to find that the nurse that would prepare and create that plan with the patient was then trying to contact the GP to coordinate the ongoing care. So I know this is deviating from what we were saying, but it was just something that was clinically important to mention, is that, and what I mentioned to this nurse, and to put it out there, is that these care plans and the nurses can contact the nurses in the general practice, because they're finding that they're not getting onto the GPs, and rightly so. The GPs are busy, etc. They're, tied up with their patients. But it is something where, if we're made aware also, we can straight away be linked in with that patient. So it's just to put it out there that those care plans can be communicated to the nurse in general practice, and then that can always then go on to the GP. So that was just a very important message I wanted to get across, and also for GPs out there to be feeling or to have more confidence in their nurses to be actually involved in this coordination of care. I think it's great that we're talking about this and talking about a particular case and unmet needs and all of that, but we just, I think, also have to be aware that we need to have the confidence in our nurses to be able to identify these needs, these unmet needs with patients, and be able to coordinate that care going forward and the communication with the GP. And also to put out there as regards resources, that one of the areas that I learnt with this clinical placement program, I was just gobsmacked at the amount of resources that are available in some of our public hospitals that patients, really have no idea about. Education forums, sessions, treatment, massage, it was just amazing. So there is so much out there and that is available. It's just tapping into it. Sorry, I had to deviate there to get those points across.
No, that's absolutely fine, Ross. Catherine, Magali, any points to add, I guess, on the area of unmet needs?
I was just going to add, we're lucky enough at the moment to have telehealth items covering all of our chronic disease items. So it's a great time to even be proactive about that care that we provide, because even for nurses, we have that nurse monitoring and support item that can be done up to 5 times in a calendar year. So that's some funding. It's not incredible funding, but it's something, and it's a sort of a recognition of how you can be better utilizing your nurses for that proactive care, for that follow-up, for that, checking in, how are you going, and yeah.
Magali, I think that's a really good point, and a segue to, I guess, the tools that that we've got during COVID-19. everyone in primary care knows about 721, 723, 732 times 2. We've got also the 2715, 2713, the 2712s. What's happened with COVID-19 and telehealth and video health numbers? Can we still do care plans in COVID-19?
We definitely can. And for a lot of practices, this is going to be the most important pivot that you can do to stay financially viable, because a lot of practices during COVID and when telehealth came in, some practices have shut their physical doors. Some of them are working part-time with telehealth, and a lot of practices are bulk billing, or they feel like they're forced to bulk bill, or sometimes we have to bulk bill depending on the patient profile. So particularly private and mixed billing clinics are taking a huge financial hit to the point of almost non-viability. So being able to pivot, use your nurses, not just reduce their hours or get rid of them, use them to be really proactive about chronic disease with the chronic disease items, because we do have telehealth equivalents for all of them. Chronic disease items, that is. So for your GP management plan, your team care arrangement, your reviews of those items, your mental health items, which obviously your nurses wouldn't be doing those, but they're available obviously for the GPs, and for that nurse support. So they can either be done via phone. Obviously the ideal is telehealth video, a video and audio link. But if that's not available, yeah, telephone is another option. And patients really appreciate it. Like it's one of those things where, having been involved in other research projects in the past where we've actually chased up patients and go, what is it, what would it be like if your GP was actually following up regularly? They love it. And they understand that it's difficult, for a clinic to do it. But if you can have a practice nurse touching base, once a month, even once a quarter, going, hey, how are you going? I'm mindful that you had these things coming up. You've got a review coming up. That is just incredible. And the kind of loyalty that you get and that relationship, that trust, it just does amazing things for that.
Thanks, Magali.
I think also, Justin, if I could just make a point, over this particular time, the chronic disease management plans are paramount, given that a lot of specialists, radiologists had closed down for a period of time. And so it's like, did some care or has some care then been a little bit lost to follow up? And this is a vital component to be able to find that and then renavigate back on board to where we're heading. So absolutely paramount in this particular time.
Thanks, Ros, an important point. I guess the next thing I like to talk is about optimal care pathways, health pathways. I noticed in some of the questions and answers it's been asked, and maybe Joe and Ros, health pathways, the information on the Australian Cancer Survivorship Centre, optimal care pathways. There's a lot of information out there. Are they linked? Are we able to actually go to one source of truth?
So who was that for?
So Joel and you, Ros. Maybe start off with Joel.
Yeah.
Well, I mean, definitely health pathways are very localized. So I'm not aware of, I can't be sure whether every health pathway is incorporated, the resources available from Australian Cancer Survivorship Centre. And I'm probably not the expert to talk about that. But obviously health pathways is a very good resource because it gives you that local pathway. And then the other one that might be really useful is optimal care pathway, because, and that's the one that's developed by, in Victoria, but it's actually relevant for across the whole country. And that's been developed by a whole range of experts. So you can trust the information in there. And it's meant to be, it's not just about survivorship, because it's about like from start to finish kind of thing for all the cancer subtypes. But it can be very valuable in looking up any information.
Yes, I agree with Joel. I use health pathways to assist, but not predominant by any means. And I've used the optimal care pathway, and I certainly go to a few. I wouldn't just be working on one. I know that some GPs and even GPs here have said to me, you know, have we got streamlined, you know, follow-up for thyroid, bladder cancer, you know, breast and etc. So, I mean, obviously we're in the process of creating that, but I tend to span out, you know, do the hospitals, health pathways, Cancer Council. I just don't identify with one and just work with one.
Thanks, Ros. I guess, you know, Meg, we've got on the Australian Cancer Survivorship Centre website, the mycareplan.org, and, you know, Ros, you talked a lot about the importance of care plans, and, you know, good information, you know, allows for fantastic care. Meg, what are your thoughts about care plans, whether it comes from a GP or whether a patient initiates their care plan with the providers? I'd be really interested in your thoughts on the matter.
My own care plan is an Excel spreadsheet that runs to 5 pages, because in the days that I started my journey, there was no such thing. I would have killed for something like mycareplan.org. It is a facility that's been created by the Australian Cancer Survivorship Centre that allows healthcare professionals, patient survivors, to be able to go online and create a care plan. Care planning, the capacity to have a care plan, to be able to have a document that contains all of the information about your diagnosis, your treatment, with referral pathways, access into and out of the system, side effects, late effects, all the things that we've talked about, is absolutely vital for every patient. And I personally am delighted to see that care plans are being increasingly used and shared with primary health care and the patients, and that patients are going away from treatment with a care plan in their hand, or the ability to make one for themselves and to use that to travel between the relevant healthcare systems. One of the biggest things for me was moving from one cancer stream to another. Without a care plan, all that information is lost. You go on to a new specialist and they really don't know what's happened before. So it's vital for patients to have that ability to be able to create a care plan for themselves, with their doctors, with their GPs. So yeah, vitally important.
Thanks, Meg. I guess you know, we're coming to the end of the webinar, and obviously we'll take questions and answers. Catherine, you've mentioned some of the supports available through your valuable service. Can you give us a more detailed examination of supports and services available for both those affected by cancer and healthcare professionals? And I noted there was a comment in the Q&A that yeah, what happens, and we did mention briefly, you've exhausted all the available, I guess, item numbers to see allied health, psychologists. We can go to possibly community health centres, but I guess your expertise, is there any other, I guess, areas we could actually go to provide good care for our patients?
Yeah, absolutely. And I see the questions there too. And I'll come back to what are some of the options that Cancer Council may be able to assist with if people have exhausted sessions through mental health care plans and other plans that are in place. To give I guess, more of an overview of what Cancer Council can do, by calling our information support line 13 11 20, that's accessible nationally, no matter what state or territory a person is in. And that can be accessed by anyone with any question about cancer, whether that was someone wanting to know about their risk, possibly their risk of recurrence, whether they are a cancer survivor, a carer, or a health professional of any kind working in cancer care. That line exists as a complement, as I said earlier, to clinical care. So we act as a navigation and referral point to connect the dots in some ways between primary and acute care, and to understand what services people need, what they've already accessed, what are their new options to them. But the biggest thing we've been talking about throughout, one of the things that we're able to do is really focus in on what it is that the person needs right now, making sure that their treatment has been taken care of, their side effects are being well managed, And if those things aren't happening, we can help point them in the right direction of where to go to get those things addressed. And once those things are addressed, or they have a plan in place for how they can be addressed, we can really then focus in on the unmet supportive care needs, either for the person affected or for the carer or the health professional, as we mentioned. So in terms of the question that's been asked around what are the options for potentially accessing things like allied health or mental health options, cancer councils around the country do have options where we can provide free of charge counselling services or low cost counselling services for people that have exhausted options in their local area. There are often face-to-face or via telephone options. For other people who may need more of that peer support focus, but for peer support volunteers who have had training around how to support someone with cancer, and Meg mentioned her experience earlier about being a Cancer Connect volunteer, there are peer support options that we can link people into where they can speak to someone specifically that's been through whatever side effect or concern they're experiencing. If we think about our case study, there was some mention here around sexual dysfunction and fear of cancer recurrence. That's absolutely something that either our nurses on the phones can speak about and unpack with them in a bit more detail, can refer them into specialist services, maybe low cost or free of charge, can link them in with peer support to talk about a lived experience with someone who knows what it's like to be the same age in a relationship, dealing with an ileostomy, what that does to your own personal impacts of your sense of self. You know, even with Ben, there were things talked about there around the impact of return to work and financial toxicity. I would definitely echo that is fast becoming one of the first things that people will pick up the phone to speak with us about, is some sort of practical issue. Financial toxicity is being recognised now as a valid side effect of cancer treatment, much like hair loss or you know, whatever that may be. It's getting to that point now. So being able to speak with people candidly about where they're at, what services they may be able to be linked into, whether that's financial counselling or financial planning, and return to work services are also things we can talk to and help people access. One of the things I'd highlight with Cancer Council services is that most of them are free of charge with very little eligibility or screening criteria, and that is why we exist, to fill those gaps. In terms of allied health, XMed was mentioned earlier. That's one of the best ones that we've got in terms of cancer-specific survivorship care when it looks at exercise physiology and exercise and how that plays into survivorship. So really, when we think about optimal care, if people aren't familiar, they're resources that were mentioned. They were created in Victoria but available nationally. They sit alongside things like the care plans. They tie into health pathways. And along the side of, if you look at an optimal care pathway at a specific tumour type, it steps you through what is expected at each point in someone's care. And running along that whole trajectory there is the idea that assessment of supportive care needs should be looked at, both for the person but also for the family, whatever that family or support network may look like. It's really important that those needs are looked at holistically. And you know, amazing examples of what's been suggested between Ros and Magali and Meg reflecting on her own experience. But Cancer Council and the Australian Cancer Survivorship Centre exists specifically to help you to be able to identify what those needs are. If for whatever reason your health service or your practice can't meet those needs yourself, that is where you can refer on to allow us to pick up and to carry on where you have left off, and vice versa. We will make sure that they're linked back into you if we know that they haven't accessed what is available to them through their primary care practice as well. So we very much, I would like to think, although we're not physically working together in a sense, I think that awareness that we create of each other and what we all contribute to the person's care is really important, because no one of us on this webinar could do it ourselves, and we can't meet every single need for every single patient in isolation. We do need to work together, and most importantly, as has been mentioned throughout, guided by the person at the centre of that. What is it that they need? It's not about what we think they need. A lot of the time we'd have a pretty good hunch, but it is really important that we are always guided by the person at the centre of that and what they need right now, and to meet them where they are, as has been mentioned earlier.
Thanks, Catherine. And yeah, I was just reflecting, just looking at all 5 of your faces. You know, what a team we've got. We've got, you know, Meg is a cancer who's been managed well. And obviously we've got Catherine from Cancer Council, MacCallum, Ros from Primary Care Nurse Networks, and obviously Joel Reed. So we've covered a lot. What we might do is actually go to questions from the group and from the participants of tonight. But before we do that, Michael Jefford did mention a really fantastic link that links directly to the optimal care pathways, but specifically written for primary care clinicians. So I would urge all of you to look at that link, and obviously it gives you great information how to manage your patients with cancer. There was a question, do GPs feel they have enough education to undertake shared care follow-up of examinations such as pelvic and vaginal exam after endometrial cancer? I'm not sure who to throw to first. Joel, I might throw to you as the GP, obviously from your perspective as a clinician. Is there any education that we can do through continuing professional development on this area?
Yeah, I think, I mean, most GPs would be very competent at conducting such examinations. Like some GPs would be doing multiple pelvic and vaginal examinations in women. I mean, not for endometrial cancer or after that, but for as part of women's check or as part of cervical cancer screening test. They'll be doing that every day. And they become highly competent at that procedure. So I don't think that'll be an issue for most GPs. I think probably what would be useful for GPs is basically what specific things should they be looking out for. Just those sort of information would be particularly helpful, I think.
Any other comments from the panel?
I was just going to mention probably having recently dealt with specialists and GPs in a family case, it is so good when the GP and the specialist have a direct relationship. It's not just letters here and there, like they actually can get on the phone and talk to one another about, hey, what do you think about this? I'm thinking of putting them on this medication. This is going to be an issue. That is invaluable. So I think the more that GPs feel comfortable, and I know it's not always easy, but just reaching out to the specialist going, hey, I've got some questions. Is it possible to have a quick chat? You know, you may not get through, but the chances that you might, and you might be surprised that sometimes specialists actually are quite keen to, get that information across. So that relationship, I think, and being able to ask those questions of the treating specialist is invaluable. And it's just so reassuring also as a patient to know that there's that communication happening amongst the team. Yeah.
I guess, MacCallum, just touching up, I'd be interested in other panel members. There's been a comment made that sometimes hospitals and quaternary hospitals, the specialist teams, the GP or the primary care service, they're not really required. They're invisible. Are there any tips or, I guess, pointers or, comments that you could actually see what we can do in 5 years' time to actually break through and connect us in a much better way to support our patients?
Difficult one. If we did, I'm sure it'd be happening already. And that's what I find, like on the St. Vincent's GP Liaison Board, we're always, this is what it's about, talking about improving the communication between specialist, hospital and GP. I think what diversifies that is that your various hospitals will have their own cultures. And that's where I think you do get the difficulty, because it's not all streamlined and you have to work with, their mechanisms, their culture. So, it'd be great for any way to improve it, but I don't think it's an overnight quick fix by any means.
Meg, any thoughts on the matter?
Hospitals talking to GPs, goodness me. I've got one fantastic thought on it, but it would take an awful lot of money and it would be a federal government initiative. And that would be that
it's a blue sky idea, we'll take it.
in fact, that they had systems that talk to one another. That would be the biggest step to start this whole process. I think the difficulty of systems talking to each other is one of the biggest issues between hospitals and primary care. But that doesn't mean that you can't pick up the phone or you can't use an email, you can't get on Zoom or whatever. And I think COVID has shown that, in fact, we can all talk face to face, and it's one of the things that maybe we can incorporate even more into the conversations that are had about patients by all of their treating team, and if the patient is the centre of that conversation and shared care perhaps is the outcome, then they should be able to talk to one another.
I think, Meg, what you've mentioned is, although we are having a spike in Victoria, we've used the last 3 months preparing, and that's where technology, we've had to become nimble at the hospital. Being a GP, but also being at St Vincent's, for our instance, dermatology is all done by telehealth. We were planning to do it over a 2-year plan. We had to do it in 2 weeks. So I think there is opportunity to use the catalyst of, well, is it too hard when we're devising a care plan for a patient with cancer? Well, can we organise a time for a video, a Zoom conference, a telehealth? Can we get input? And if not, that conference that is held in MDN is recorded, and if need be, the GP can view it. So he or she can feel part of the care team. So I think using technology and good communication in a new way, that might be something to consider. Hopefully it won't cost the government too much money with your blue sky idea. I might move to, I guess, rural health and rural survivorship and, the planning for our care. We know rural patients don't do as well. I guess interested in comments, Catherine, Magali, as to, are there ways that we can really improve outcomes and, successfully treating and managing patients in our country setting?
I'm happy for Magali to, I guess, pick up on the triage of actual treatment and care in that perspective. From a supportive care point of view and Cancer Council, I think that's something that the benefit of all of our services from a Cancer Council point of view is that they're accessible either via phone, online, whether that's via telephone support groups, accessing the nurse-led information line. Our peer support is either online or via telephone, via web platforms, and much the same. I think COVID has forced us into new ways of working, a lot more online training delivery, whether that's for patients and their families or whether it's healthcare professionals who are wanting to develop their skills and their knowledge in a cancer setting. So I think, in many ways, while it did throw us off course for a minute there, we righted ourselves very quickly and have moved far quicker than we would have otherwise into new ways of working, new modes of delivery. Lots of focus on improving communication around telehealth. I think while telehealth has been fantastic in so many ways, because it moved so quickly as it had to, there's still a lot of catching up to do in terms of best practice communication, bringing people along for that journey. A lot of patients have a huge amount of apprehension around telehealth and how that works, in what settings it's applicable, where face-to-face should still be important, how the two work together. How you build a rapport with someone if that's the first time you're meeting them and if there's no video link available. There's lots of things to consider that outside of just that treatment perspective. I think from a rural perspective, we're also looking at lots of ways that we can make it easier for treating centres and healthcare professionals to refer to our services directly. So rather than just encouraging someone to visit our website or to pick up the phone and give us a call, we're working on formats to make an active referral into our services part of normal care. It doesn't sound like a groundbreaking idea, but it's a lot easier said than done sometimes. So I think COVID, from our perspective, has afforded us an opportunity to really look at how can we entrench those referral pathways to take the guesswork out and to take the onus off the patient to have to remember everything, and to actually capitalise on those relationships that primary care are building with their patients. So, for example, Magali and Roz or Joel, if you were to refer your patient and say, this is what I would like Cancer Council to be in contact with you about, X, Y, and Z, I'm going to put in a referral for you. They'll contact you on X. They have that faith and that trust because you've referred them to know that, okay, well, if you've said it's a good thing for me to do and that's what they're calling me for, great, I'm all for it. Whereas it's probably less likely to have the same impact if someone had to necessarily follow that up on themselves. There are some great, self-driven patients who do that. But the benefit of doing that with Cancer Council as well is they're not just going to get the benefit of whatever we can provide from a Cancer Council perspective. They'll get the benefit of being referred to, again, other services that may be able to support them. So, Magali mentioned, for example, if someone's got ovarian cancer and I don't know much about ovarian cancer, what the heck do I do? Refer to Cancer Council. We'll go through that with them. We'll talk to them about their specific needs. We'll fill the gaps that we can fill. We'll refer them on to Ovarian Cancer Australia. We'll link them in with those specific supports and get them that tailored information. So we'll build on whatever has already been provided and we'll fill those gaps. So I know that's a very long-winded response to a rural and regional question, but I think it highlights that loop that we create, and especially in relation to COVID, when everything is being done virtually now, I think it's really giving us a chance to fill some of those gaps that were only originally experienced by rural and regional areas.
I was going to add to that. I think with now this sort of telehealth world, and this is anecdotally because I don't actually have the data that backs this up, but anecdotally from talking to a lot of clinics, it seems like strangely clinics in more rural and remote areas haven't actually seen the uptake in telehealth that we have seen in more metro areas, ironically, seemingly, because you would think that that's actually the more convenient, but if anything, like a lot of those clinics are the ones that are really struggling because it's like, well, they're not coming to face-to-face, they're not engaging. So I think a big part of it is going to be that continuous education and reassurance, because a lot of it is just this like not being sure what this is about, how this is going to work, is it going to be too techie, and is it going to be like what's going to happen. So it's almost like being in that position if you're in a rural and remote practice where you're continuously educating, you're helping them break the ice and sort of become comfortable with, what's a telehealth consultation, what does that look or feel like. There's also the ability to have facilitated specialists, which we had like the telehealth items before telehealth was a broad thing. The specialist telehealth items for people in rural remote areas that would be facilitated with a GP there. So that tends to be the challenge there, is finding the specialists and the services that are willing to liaise with those GPs or convincing the GPs that it's going to be worthwhile to set those up. But I know with a couple of groups where that's working really well, and the GPs love it because they themselves get to, they get to be part of that consultation. They get to ask questions. They get to learn from that as well. So I think it's just going to be a gradual education and reassurance process.
Thanks, Magali. And I've noted a comment from one of the participants. As a clinical nurse consultant in a specialist centre, I think myself in rural cancer care setting, rural cancer care corners can be the conduit between the acute sector and the primary care. As I tell my patients, we are just a phone call away. So I think it's combining the know-how, the new technologies, but in the end, in each town or each rural setting, knowing who to go to, who's the right person. It may be a different person in each rural setting. I see another question, question about how to get more out of shared care and regarding implementing breast cancer shared care. I work in a treating centre and want to support women to access more care close at home. Are there tips to implement this successfully? Maybe Meg, I'll throw that to you first for comment and then others to contribute. How to maybe set up a centre of excellence for shared care in breast cancer?
I can only go by my own experience, and that is that I have in terms of follow-up, for my breast cancer, there's not a huge amount of follow-up that I actually require, having had a bilateral mastectomy. But for most breast cancer patients, they're going to be needing still regular mammograms and there's screening tests and what have you. So in terms of those things, they are so easily done through primary care, and my follow-ups initially were once every 6 months and then once a year with the oncologist. When I went into shared care, that then transferred directly to my GP. All of those things can be done in the community. There's no need to go back to the treating hospital to have those tests done, whether it's for breast cancer or any other. Your blood tests and your scans and your screening can be done in the community just as easily as they can be done by the treating hospital. I think the others are probably more expert in what is required technically, but from a consumer point of view, it's too easy.
Any other comments from the panel?
Yeah, Joel here. I think in terms of shared care model, the making sure that there's clarity of the roles is really important. So, because often you can have really good communication, but if people aren't quite clear on who's going to chase what result or who's going to be ordering something, or maybe, I don't know, the primary cares are thinking that if we order this investigation, then the specialist center will chase it up, or, you know, all of that can actually lead to breakdown in communication and can lead to things getting missed, or the patient just, you know, going on suffering from unmet need, or could, you know. So I think just making sure that you have that clarity, and survivorship care plan, I think, is a really good document to have, especially the one that's detailed and the one that stipulates, you know, what the roles and responsibility for each person, each party is. And that's also very easy for the patient to see, because without a written document, it's, you know, it's very sometimes hard to keep on track of everything, and you end up having a folder. I think many patients end up having a folder, and having a survivorship care plan would make that job, you know, work a lot easier for patients, I think.
Anyone else want to add anything to Joel and Meg's comments? Thanks, Meg, and thanks, Joel. I'm conscious that we are at 8:27 and we are concluding at 8:30. Meg, you're on this road, and are there any final take-home messages for health professionals when providing survivorship care? And I guess a follow-up question, what is important to you, you know, in regards to this evening and getting a message across to our participants?
I think I probably need to finish with what I started, and that is to say that I hope that I've managed to put a face to survivorship for the participants tonight. But I guess the message that I would like to finish with is that I sat down recently and I made I started a list. It probably doesn't cover everything, of what I would call my survivorship essentials. And I guess to finish, I would share those with you. And that is, the very top of the list is that I have a relationship with a trusted GP. If I'm concerned about a lump, a niggling ache or a pain, I have it checked out. I don't wait. I put my trust in my treatment team and follow their guidance and advice. If I don't understand, I ask for more information or for an explanation. I reach out when I need to, and I accept offers of help from family or friends. I try to lead a healthy lifestyle, eat fresh food, walk, exercise, don't drink too much. I'm sun smart. I maintain my screening appointments and my checkups, and I have a survivorship care plan. And that is where I would finish. Thank you.
Thanks, Meg. And I just want to thank each of the panel members, Meg, Catherine, Joe, Magali, Ross. It's amazing to hear of your wisdom and your insights for this evening, and we thank the participants for attending. What people don't know is there's a huge back end crew that's been supporting us this evening from the Australian Cancer Survivorship Centre along with the RACGP, and they've just put me a reminder in my chat box that there is one poll that needs to be done, and that's where I'll throw to the poll. And the last poll is survivorship care is an important part of your role. And hopefully we've been able to answer some of your questions tonight and also offer you some information how to give best care to our community. So we'll finish off with this poll. And to finish off, we had 80% strongly agree survivorship care is an important part of our roles as primary care clinicians, and agree again, saying 100% success rate for this evening. Again, thank you for the panel members. Thank you for the crew that supported the evening. Also, the many people that have contributed to the resources and sponsorship of this webinar. So on a cold, wintry Melbourne evening, I will say farewell and thank you to all the participants and webinars. Good evening.
Thank you.